Hey, good afternoon, everyone. Welcome you all in Pedia Academy by Dr. Pankaj. So, again, I welcome you all in this channel and our new test series, which is NEET SS Pediatrics test series, which is divided into 72 subject wise or topic wise test. We'll discuss it later also. So, without further delay, let's start our discussion. So today we will discuss cardiovascular system table discussion. Before that, I have a very important announcement. We have launched our Android app for Pedia Academy. This will smoothen user experience and give users more free hand in using the test and other things. So please go and download this mobile app. The app link is in description. So without further delay, let's come to our discussion of CVS tables. First is vascular rings. This is actually now a hot favorite topic of examiners now. First we will discuss double arch. As you can see in this image, these are double arch. What are the double arch symptoms? So symptoms are like stridor, respiratory distress, swallowing dysfunction, and reflex apnea. Plain X-ray film, AP film, wider base of heart will be seen, and lateral film, narrowed trachea will be seen. These are two important things. And in this condition, on both esophagus and trachea, there are compression or indentation signs will be present. So both trachea and esophagus will be indented. What is diagnostic of this condition? Remember, this is potential question. Double aortic arch, double arch is diagnosed by MRI echo. This is very much important. MRI echo is the entity, and the treatment of double arch is ligate and divide. Smaller arch usually left. So this was INI SS PYQ. So they'll say divide larger arch or divide smaller arch. Then the answer is smaller arch, usually left side. Very much important. Next entity is right arch and ligamentous ductus. So in this condition, same thing will happen like respiratory distress and swallowing dysfunction. AP views tracheal deviation to left, right arch. In this also, bilateral tracheal and esophageal indentation or compression will be seen. Right is more than left. Similar to double arch, it is also diagnosed by MRI echo. And treatment of this condition is also ligate ligamentum or ductus. So this is you have to remember. Another entity is anomalous innominate. Okay, in this condition, the symptoms are cough, stridor, reflex apnea. Just see the difference. In this condition, AP X-ray will be normal. Lateral X-ray will show anterior tracheal compression, but AP will be normal. In this condition, barium swallow is normal. So, double arch and right arch having indentation of esophagus but anomalous innominate artery having normal barium swallow. On bronchoscopy, pulsatile anterior tracheal compression. Remember, these are anterior tracheal compression. MRI echo will not be requiring and treatment is conservative. Another entity is aberrant right subclavian artery. Okay, in this condition, no respiratory symptoms will be seen. That's why occasional swallowing difficulties will be there, but bronchoscopy is normal. Okay, plain film will not show any abnormalities. Plain film will be normal. Okay, AP view on barium swallow is oblique defect upward to right. MRI echo is also diagnostic of aberrant right subclavian artery. The treatment is simple, ligate that artery. Pulmonary sling, this was previous year's NEET SS question. So, expiratory stridor and respiratory distress, just see, swallowing difficulties are not there. Okay, so in this condition, as you saw, AP is low left hilum emphysema atelectasis changes will be seen, and on barium swallow it may be present or absent, plus minus anterior indentation above carina between esophagus and trachea. Bronchoscopy showing tracheal displacement to left, compression of right main bronchus, and MRI echo is diagnostic. Okay, so what is the treatment of choice is detach the re-anastomosis to main pulmonary artery in front of trachea. You have to revise this vascular ring stuff once again. They'll ask which is the important investigation to diagnose these condition, treatment of these condition, what is the bronchoscopy finding, what are the barium swallow findings. Okay, so these are actually 3 to 4 potential MCQs can come from this important table. Okay, next we will discuss TAPVR. Okay, total anomalous pulmonary venous return, site of connection and percentage with significant obstruction. Okay, so in connection, supracardiac connections are most common. These are 50%. Okay, most common. Second most common are cardiac, and infracardiac are 20%, mixed are 5%. So you can say it is supracardiac are most common, then cardiac, infracardiac, and mixed. Among supracardiac, which is most common? So in this condition, left superior vena cava is 40% obstruction, and right superior vena cava is seen in 75% of significant obstruction. So they'll ask in supracardiac which will have more obstruction, that is right superior vena cava more than left superior vena cava. Cardiac, coronary sinus is having 10% obstruction, right atrium having 5% obstruction, and infracardiac, just remember almost all of infracardiac having significant obstruction. So this is those simple looking table, but it will contain many MCQs. So please stay attention. Stay your attention in this table. This is very important. Okay. Next, we'll discuss diagnosis of tachyarrhythmias. Okay, so these are tachyarrhythmias, electrocardiographic findings. Sinus tachycardia, all we know, heart rate should be less than 230. So this value you have to remember. Always P wave will be present, axis will be normal, QRS will be normal, other things will be normal except rate, rhythm will be normal. What is atrial tachycardia? Rate between 180 to 320. P wave will be present, but it may be abnormal. Okay, QRS duration may be prolonged, and regularity usually regular, but ventricular response may be variable. Okay, so this is the thing. Second thing, arterial fibrillation. In this, heart rate is 120 to 180. As name suggests, P wave are fibrillatory, QRS duration is normal or prolonged with aberration, and regularity are irregular interval. No 2 hour R interval are alike. You have to remember that. Next entity is arterial flutter. So what is the difference between arterial fibrillation and flutter? Just we will see. In this, arterial rate is 250 to 400, and ventricular response is variable 100 to 320. And in this condition, the characteristic P wave will be seen, that is saw wave, flutter waves. Okay, QRS duration will be normal or prolonged, and regularity is a regular ventricular response, that is 2:1, 3:1, and 3:2. Next entity is junctional tachycardia. In this junctional tachycardia, the heart rate will be 120 to 280. Just remember, P wave atrioventricular dissociation with no fusion and normal QRS capture beats. Very much important. This statement can be asked in exam. What are the P wave characteristics of junctional tachycardia? QRS duration is normal or prolonged, and regularity is generally regular. Ventricular tachycardia (VT). VT generally having heart rate of 120 to 300. In this condition, atrioventricular dissociation with capture beats and fusion beats. Okay, QR duration is prolonged for age, very important, and generally rate is regular. So in this condition, this table, just remember the rates, the heart rate classification, the P wave characteristic specifically of atrial flutter, junctional tachycardia, ventricular tachycardia, QRS duration, generally C. For VT it is prolonged for age, and regularity you have to see. Okay, again this is simple looking table, but it contains many things which has to be remembered. So again, a reminder for all of you, we are conducting 100% Nelson-based daily test series for NEET SS Pediatric, which will contain 12-week long daily test series. Almost daily tests will be there. 72 subject by topic test, 6 full-length grand test. This will be 100% Nelson based. This is the first test series available on 100% Nelson based test series, 100% exam oriented. So this test series is live. Do check out in description. Without further delay, we will discuss these recommendation of 2023 European recommendation of antibiotic prophylaxis in patient with CVS disease undergoing orodental procedure at increased risk of infective endocarditis. Basically, these are dental procedural guidelines of IE. Okay. So, antibiotic prophylaxis is recommended in a patient with previous infective endocarditis. If any patient is having in previous infective endocarditis, yes, you have to give prophylaxis. Antibiotic prophylaxis recommended in patients with surgically implanted prosthetic wall and with any material used for surgical cardiac repair. Okay, so in this condition, if implantable prosthetic wall is there, you have to use prophylaxis. Okay, another thing, transcatheter implanted aortic and pulmonary valvular prosthesis. So these are direct line which will be asked in exam in this table. This table is very much important. Okay. Transcatheter mitral or tricuspid valve repair, yes, you have to go for prophylaxis. Untreated cyanotic CHD and patient treated with surgery or transcatheter procedures with postoperative palliative shunt, conduits and other prosthesis. Okay, so this is after surgical repair. If no residual effect is there, the prophylaxis is recommended for first 6 months after the procedure. So just remember, these will be potential MCQ. Just mark everyone in your mind. Okay. So these are actually 1, 2, 3, 4, 5, 6 MCQs can be made out of this table. These are latest 2023 European recommendation on dental procedures in infective endocarditis. Okay. So echographic echo findings in rheumatic valvulitis. So if we are labeling any patient with MR, okay, so there has to be four criteria should be met. Similarly for AR, we'll compare both simultaneously. So just see, in MR it is seen in at least two views, that is same in this. Okay, jet length is more than 2 centimeter in at least one view, and jet length is more than equal to 1 centimeter in at least one view. Peak velocity is same, more than 3 meters per second for both, and pan systolic jet is there in MR and pan diastolic jet is in aortic regurgitation in at least one envelope. In this table, you have to remember these two differences: more than 2 centimeter jet length, more than 1 centimeter jet length, and pan-systolic and pan-diastolic. So these are very much important. Okay. So this was previous year NEET SS question. Again, the prophylaxis of secondary prophylaxis of international guidelines, generally it's keep changing, but as of given in Nelson, American Heart Association, they say three conditions: acute rheumatic fever with carditis and residual heart disease. First thing. Second thing, ARF with carditis but no residual heart disease. Second thing, ARF without carditis. Third thing. Okay. So first thing, what will this they are recommending until 40 years of age or 10 years after the last ARF, whichever is longer. In second entity, they are saying until 21 year of age or 10 year after last ARF, whichever is longer. ARF without carditis, they are saying 21 years or for 5 years in the last ARF. So, for simplification purpose, just remember 40 10, 21 10, and 21 5. This you have to remember. ARF with carditis with residual heart disease, no residual heart disease, and no carditis at all. So, this formula you have to remember. Many questions are expected out of this. WHO criteria of 2004, they are saying it should be given lifelong if severe valvular heart disease there, and for 10 years after last ARF until 25 years of age with previous diagnosis of carditis. If no carditis is there, for 5 years at least ARF and until 18 years. So lifelong, okay. So 25 10, 18 5. So these formulas, any mind map you want to remember these, but you have to remember because these are a very confusing number and they often end up in silly mistake in exam. So please remember this condition. Okay. Another thing we are discussing is, which is very important, definition of infective endocarditis modified Duke criteria. So there are pathological criteria in this condition. Just remember, microorganism demonstrated by culture or histological examination is first, or pathological lesion, vegetation, intracardiac abscess confirmed by histological examination. Okay, so clinical criteria are two major criteria, or one major criteria and three minor criteria, or five minor criteria. Okay, so just remember these clinical criteria. We'll discuss what are the major and minor, but remember this. Okay, possible infective endocarditis, one major and one minor and three minor. Okay, we'll discuss what is the major criteria and what is minor criteria, but as of now these are clinical criteria. Okay, rejected diagnosis, don't remember this. Okay, so what are the major criteria? Blood culture positive finding of infective endocarditis. First thing. Second, evidence of endocardial involvement. Second thing. Okay. And new valvular regurgitation, worsening or changing of pre-existing murmur is not sufficient. So this was asked. I will tell. Okay. So blood culture. What is the blood culture criteria? Basically, typical microorganism with at least two cultures. Okay, what the typical microorganism? Just read these organisms, but it should be typical. Microorganism with IE consistent with infective endocarditis from previously positive blood culture finding defined as at least two positive culture finding blood sample drawn more than 12 hours apart, three or more of at least four separate culture finding of blood, and single positive blood culture for Coxella brunetti or anti-phase IgG titers more than 1:800. Okay, so this is blood culture finding positive for infective endocarditis. Okay, evidence of endocardial involvement, this is also important. In this condition, echo you'll do and you'll see oscillating intracardiac mass, okay, abscess and new partial dehiscence of prosthetic wall. Minor criteria, just remember, predisposing condition, temperature more than 38, just remember this temperature criteria. Vascular phenomena like septic pulmonary infarct, myotic aneurysm, intracranial hemorrhage. Immunological phenomena like glomerulonephritis, Oster node, Roth, sport and rheumatic factor. And microbial evidence like positive blood culture finding but does not meet the major criteria. Basically, this is very important. You have to remember all these which we have discussed and highlighted. Definition of infective endocarditis and modified Duke criteria. So this slide is ultra. So just to remind you all, we are having ongoing test series of NEET SS Pediatrics 2025 at pediacademy.com, and we have our app also. So do check it out, test series. It is in very affordable price. Currently we are conducting 25% off on it. Okay, so do check it and subscribe. It is directly from Nelson based. So without further delay, we'll discuss our discussion of cardiomyopathy. Okay, so cardiomyopathies are like DCM, dilated cardiomyopathy, hypertrophic cardiomyopathy, okay, restrictive cardiomyopathy, LVNC and ARVC. Okay, basically left ventricular non-compaction is very important entity because this is potential to be asked in exam, and arrhythmogenic right ventricular cardiomyopathy is also important. Just remember prevalence because sometime one time in exam prevalence will be asked. So this is you have to remember. Okay. So what are the causes? Cause is basically sarcomeric cytoskeleton desmosomal gene. It is common for everyone except ARVC. Desmosomal gene variants are there. Okay. Inheritance, as you'll see, 30 to 50% autosomal dominant in case of DCM, 50% autosomal dominant in case of HCM, RCM is autosomal dominant in 50%, LVNC is autosomal dominant, X-linked and mitochondrial. Percentage are not known, so question will not be formed here. ARVC 30 to 50% are AD, except rare autosomal recessive. They'll ask B syndrome, Nexus disease, and Carvajal syndrome. These are a variant of ARVC which are autosomal recessive potential MCQ. Sudden death, yes, this is associated with every cardiomyopathy. Arrhythmias are arterial, ventricular, and conduction disturbances in three of these conditions, but HCM and RCM having arterial and ventricular fibrillation case of HCM, and RCM is arterial fibrillation. Ventricular dysfunction. So in this condition, systolic and diastolic dysfunction are seen in DCM and uh, DCM systolic and diastolic, and LVNC systolic or diastolic. So this is the difference we have to see. But in HCM, diastolic dysfunction will be there, and RCM, diastolic dysfunction, normal systolic dysfunction will be there. Okay. ARVC, normal reduced systolic and diastolic function. Normal, it can be normal or it can be reduced. So what are the previous year questions in this condition? They'll ask the prevalence, they'll ask the genetics, they will ask inheritance, they will ask arrhythmias type, and they will ask ventricular function in form of systolic or diastolic dysfunction, which is very much important. Now we'll go classification of heart failure by left ventricular ejection fraction. Okay, so in this condition, this is very much important. They have classified it as heart failure with reduced ejection fraction. So acronym is very important. This is written like this, and in this condition, left ventricular ejection fraction is less than 40%. Heart failure with mildly reduced ejection fraction, it is written as this. They'll ask percentage of this left ventricular ejection fraction percentage. It's 41 to 49%. Heart failure with preserved ejection fraction, this is acronym, and they'll ask left ventricular ejection fraction is more than 50. Heart failure with preserved ejection fraction or improved, they will write like this. So prior it is less than 40, now it is more than or equal to 40. Okay, so this classification of heart failure based on left ventricular ejection fraction is new thing, and it was asked once in INSS already. So this is potential upcoming question. Just remember and revise this. Okay, so New York Heart Association classification of heart failure. So this is actually simple, but simple things are generally asked more in exam. So NYHA classification of one, there is no limitation of activity. Okay. Second, slight limitation means they can regularly walk, but they can't run, they can't go to stairs. If they go to stairs, then uh, breathlessness will increase, symptom will increase. Okay. Third, significant limitations, like even with low level activities like walking, household chores, so they will produce symptoms. Four, symptom at rest, dyspnea or any physical activity. So this table is very important. Don't ignore this because this is uh, slightly confusing table in exam. Okay, so significant and symptom at rest you have to remember. Okay, antihypertensive therapy systemic approach, this is generally asked. So begin with recommended initial dose of desired medication. First dose, if bp's control is not achieved, you have to increase dose until desired bp target is reached or maximal dose is reached. If still BP control is not achieved, add a second medicine with complementary mechanism of action. And if BP control is still not achieved, add a third antihypertensive drug of a different class and consult a physician in CVS. So this is algorithm. They can ask anything out of this algorithm. This is simple looking algorithm, but you have to remember this. Okay, so this was all about our discussion of this important looking aspect of this. Again, I am reminding you to join our course of NEET SS Pediatric 12-week long daily test series, because mere doing reading or doing table discussion is not sufficient. We have planned questions based on these discussion also. The table discussion questions will be there in our test series. Along with it will have very full-fledged grand tests. So this is jackpot for who are preparing for NEET SS Pediatric. Wishing you all the best. We'll meet you in another system video. Till then, keep studying and